Okay, good morning, everyone. I hope you're doing well today, and this finds you getting to enjoy maybe a little bit of slowing down, and hopefully you're able to take care of yourself during this time. Let's go ahead and get started. We are going to talk about Chapter 16, Clinical Psychology. And what I'm going to do, give me just a second here, I'm going to pull up the PowerPoint. There it is. Okay. All right. Chapter 16, Clinical Psychology. So what do you guys see there? This is from the ink block test that I'm sure you guys have all heard of. They were developed in 1921 by Herman Rorschach, and they were originally created to work with individuals that were diagnosed with schizophrenia. After noticing that schizophrenia patients often described the things that they often interpreted the things that they saw in very different ways than other individuals. And typically these types of cards have been used to help detect any kind of issues with thought patterns or thought disorders, especially when individuals were reluctant to describe their thinking process. Okay, so the next thing I'd like you to do is take a moment and just think of a problem that you've been having. Okay, and as you take a look at these three cards, you're going to go from the Fool, the Tower, to the Star. I want you to explain to me how you would interpret your problem through looking at these cards. And I'll give you just a moment to kind of do that in your head. Okay, and what we have here, these are cards from a tarot deck, which often people that are very spiritual or mystical use. And a very famous psychologist by the name of Carl Jung would use these in his practice. And it wasn't that he believed in the power of the tarot card. It was more that if he asked his client to think of a problem that they were having and they drew out three cards, if he asked them to interpret their problem through what the cards were telling them, he could actually begin to learn much more about his client, how they viewed their problem, how they saw themselves, how they saw the world, others in their life. So it wasn't so much about whether or not the tarot cards work, it's about the individual's interpretation of what they see. Excuse me. So when we talk about clinical psychology, it is actually a bit different than counseling psychology. Clinical psychology tends to deal with individuals that are suffering from more serious mental illnesses like schizophrenia, uh, bipolar, manic depressive disorder, whereas counseling psychology is more dealing with emotional, social, physical issues that arise in our everyday life. And it's not in clinical psychology that we don't get individuals with more serious mental illnesses, but sometimes what we find is individuals that have very serious mental illnesses need much more care and intense therapy, and sometimes either inpatient or outpatient help. In this day and age, most therapists believe that treatment or therapy is only warranted if it's interfering with a person's life. If they are distraught, distressed, if they end up in trouble with the law a lot. Otherwise, if someone is satisfied with their life, they're happy with their life, they're being productive, and they don't see, any issues, and there aren't any issues arising from some unusual behavior that they have. Modern therapists today kind of have the opinion that it's really not our place then to get involved with someone who might be behaving a little unusual, but there aren't any problems in their life. And typically, for those of you that are going to go into, I'm going to very quickly, those of you that are thinking about going into psychology, particularly if you're wanting to pursue higher degrees, you either have a master's or your PhD. And the three main options with advanced psychology degrees, you can go into clinical work, which is what I'm doing. I see clients in a private setting. And if you're wanting, and one of the things there is you need to determine what type of clients do you want to work with? Do you want to work with the very seriously mental ill clients? And that will probably mean that you'll be working in some sort of hospital setting. If you're wanting to work with the less seriously mental ill, clinical, so counseling psychology in a private practice would probably be something. The second area is teaching. And with teaching, with a master's degree, you usually are limited to teaching at community colleges. If you're wanting to teach at the university level or college level, PhD is most often required. And then the same for research. If you're wanting to get into research, most often a PhD is required for that as well. Okay, so let's talk a little bit about it's the Diagnostic and Statistical Manual of Mental Disorders, briefly known as the DSM. And it is what clinicians use to help diagnose different mental disorders. It was originally created based off a manual that the Army had created during World War II to help them diagnose soldiers that were having behavioral issues. And so we're kind of back, if you remember, at the very, very beginning of the semester, psychology as a science. We kind of talked about standardization and validity. So when we talk about standardization, that is the reason that this was important. So standardization means that we're using a common set of terms and definitions and symptoms to describe a disorder and also to diagnose it. And before psychology started to standardize their mental disorders, what was happening is an individual could go and see 3 or 4 different clinicians, present themselves the same way, talk about having A, B, and C symptoms. It was affecting their life this way and that way. And what would happen is they could walk out of those 3 or 4 different clinicians' office with 3 or 4 different types of diagnosis. And that's because at the time, psychology did not have we didn't have the DSM, we didn't have the standardized, basically, book that we could go to that listed out the different types of disorders, what the criteria were to meet different disorders. So clinicians were just kind of doing their best guess of what things would be. So what this really has done is improve the reliability of diagnosis. And it means that you're more likely, if you were to see 3 different counselors and go in and present with the same symptoms and problems and how it's affecting your life, that you're more likely to get the same kind of diagnosis. And so those are the biggest advantages. And so that last one, when we talk about clinical significance, this is, again, we're talking about, is this truly affecting the individual's life in a negative way? When we talk about the disadvantages of the DSM, so one of the things that we worry about, are we pathologizing or are we diagnosing normal, typical behavior? And one of the things that the DSM has taken out over recent editions is the bereavement exclusion, because it was including bereavement as part of depression. And that was something where if you've lost someone, someone close to you has died, of course you're going to go through a bereavement process. Do we have the right to pathologize that and make that a mental disorder? Or do we recognize that that is part of the natural grieving process? Um, and other things, addictions have been difficult. How many addictions do we add to the DSM? For example, shopping addiction, gaming addiction. Is it with, are we pathologizing behavior? Are we giving people, or are we giving people kind of um, a way to excuse their behavior and not hold themselves accountable for their addictions? So we just want to make sure that we aren't pathologizing normal behavior, and that we also aren't excusing behavior that someone needs to take more accountability for. Let's see, what else do we have here? So influenced by social norms and perceptions. So this one I'm going to talk about with the DSM. Up until the 70s, it considered homosexuality to be a mental disorder. And part of that was because of social norms of the time, how the public viewed individuals of the LGBT community. And because it was something that particularly the church found to be inappropriate, what happened was the DSM transformed basically what the church considered to be a major sin into it being a mental disorder, because it was so influenced by the thoughts of the public and government at the time. And so it wasn't until, and it was in 1968, 1970, that they removed homosexuality as a mental disorder. And so what we have to be careful is, again, that we as clinicians, that we as the field of psychology are not pathologizing normal, accepted, okay behavior just because the public doesn't agree with some sort of behavior. And then also we have to be mindful of the culture that we live in. The DSM is created by a very Western culture in the United States. And so things that we might consider abnormal behavior, Eastern cultures might not consider that. And so we have to be mindful when we're working with clients that come from different cultures or different backgrounds, that we are not, again, pathologizing behavior that is very, and typical and acceptable for their culture. Okay, so this is one I'm going to describe it. This is one where I would have you guys break into partners. And so this is something, maybe if you're looking for something to do, you could do with a sibling or a parent or a friend. And what this is it kind of, this exercise helps show how difficult it is to work with someone when you're trying to, when all they're doing is describing what's going on, and you don't have something tangible like a phone that you can hold, and the person's like, this is it, it's a phone, this is what's bothering me, when they're trying to describe maybe any kind of emotional issues that they're having, behavioral problems that they're having. So what I would typically have you do is break into groups of two. And I would ask each of you, so go ahead, you can do this, think of an object, and something that's relatively simple, because you're going to be drawing these. So something that would be relatively simple to draw. So think of an object, and then you're going to take turns. One of you is going to think of your object, and you're going to describe it to the other person, and they're going to draw it out. So let's just say that, let's say the phone. Well, no, let's use a water bottle. So let's say that I was thinking of this water bottle, and I was going to describe it to to the person that I am partnered with. I can't say that, oh, I'm thinking of a water bottle. So what I might say is, I'm thinking of It's cylinder shape. So make, on your paper, draw like a medium-sized cylinder shape, but at the top, it's going to taper in a little bit. And then at the very top of that cylinder shape is a kind of, and so again, I could not call this a cap because I can't tell the person what it is I am wanting them to draw. I have to describe it. So I would say at the top, there is this kind of round thing that sits on top of it. So you kind of get the idea of what that is. And so you would each spend about 5 minutes describing the object that you came up with. And what this kind of goes to show is that, one, as the person trying to describe what a water bottle is and how to describe it in a way that someone else could draw it is very difficult. And then being the person listening to someone describing something to them and trying to figure out exactly what it is that they're talking about gives you a little bit of an idea of what it can be like to sit with someone who is, you know, yes, maybe suffering from a mental illness, but also perhaps they're suffering from some mild anxiety, the stress in their life, bereavement of a lost loved one, that it can be difficult for both of you to get on the same page. So as the clinician, you truly are understanding what your client is describing and how it is affecting their life in a way that you can verbalize that back to them so that they feel heard and understood. Okay, so let's move on and talk about anxiety disorders. So anxiety disorders, excessive fear and anxiety are two of the biggest symptoms when we talk about anxiety disorders. And what I've listed out are just some of the most common anxiety disorders that we see. Okay, so here we go. The two biggest symptoms for anxiety, and you'll want to know these for your test, are going to be fear. So fear is the emotional response to real or perceived threats. And this is the thing, fear is what's going to kick off the autonomic nervous system. So it's going to raise our blood pressure, increase our heart rate. We're going to start, we've noticed that something dangerous is about to happen, or we think that it is, there's an immediate threat. So it's going to kick in our fight, flight, or freeze process. And then there is anxiety. So anxiety is the actual physical part of anxiety. This is where we can feel, if you get a pit in your stomach, if your muscles start to tense up. So fear is the emotional response to the threat, whether it's real or perceived. And anxiety is the body's physical response of muscle tension, of feeling sick in the stomach, those kind of things to that perceived or real threat. So when we talk about treatment for anxiety, cognitive behavioral therapy, which is something that I'm going to go over in more detail later, but cognitive behavioral therapy very quickly takes a look at how our thoughts affect our emotions and how our thoughts and emotions can then start to affect our behavior. Relaxation techniques, mindfulness, meditation are often interventions or techniques that we use to help individuals with anxiety. So I'm going to skip, obviously, the handouts. What I'm going to do is for handouts for anxiety and CBT, those are going to be put out on Canvas under files. And I will, I think I'll call it probably Chapter 16 handouts. So if you want to go and take a look at any of them, you can do so. Also in Chapter 16, they talked about personality disorders. And again, you can see I've listed out kind of the most common personality disorders that we see. And this is when, and so what you're going to really notice, this is when an individual's behavior deviates greatly by what's expected from the person's culture. And again, this is where we want to be mindful when we're working with individuals that come from different backgrounds than we are, that we're mindful that the behavior that they're displaying is different or abnormal from their own culture. Let's see. So when we talk about, so the one that I picked was avoidant personality. And this is someone who has a hard time going out in social situations because of feelings of inadequacy. They're hypersensitive to any kind of negative evaluation, and it often begins in early adulthood. So they have difficulty with their intimate relationships because they're afraid of being rejected, ridiculed. They're ashamed of themselves because of their own low self-worth or self-confidence. And again, being overly preoccupied with criticism or rejection, particularly in a social setting. And then when view self as socially inept, again, this comes from very low self-esteem, very low confidence, which makes it very difficult for them to interact with others in a social setting. And sometimes people will be like, oh, that's me. I have a hard time going out and meeting new people, or get really anxious in social settings. And what I would kind of just give you a little more information about is that with avoidant personality disorders, this is taken a step further. They actually stop going out. They stop trying to form relationships because they are so worried about any kind of rejection on another person's part. So less than 5% of the population will develop this disorder. Researchers and psychologists are not really sure why this disorder occurs, and it can be typically is a combination of the individual's genetics along with their environment. And there's probably been some sort of rejection, severe ridicule early in the individual's life. Okay, so let's go on and look at depressive disorders. And once again, I've listed out kind of the most common depressive disorders. And as you can see on the left-hand side, when we talk about the common features that we find in depressive disorders, extreme sadness, feelings of emptiness or irritability, and then there are changes in the person's thought patterns. And so then we come back to significantly affects the individual's capacity to function. And again, this is where psychology would say if the person is, still functioning and they aren't feeling that the depressive symptoms that they're dealing with are interfering with their life, psychology is kind of taking the standpoint that then it isn't our business to come in and tell them, oh, but you do have problems. We really are leaving it up to the individuals to decide if their symptoms are severe enough that they feel that it is greatly impacting their life in a negative way. And one of the things when we look at different depressive disorders is we're looking at the severity. Would we classify it as mild, moderate, or severe? How long have the depressive symptoms been going on? And one of the things then we try to, in counseling psychology, we try to find out when these symptoms started to appear. Was there one event that triggered this, or has it been multiple events over the person's lifetime that have culminated in these symptoms? And then just very quickly, this kind of takes you through the depression cycle. And when we talk about it from a cognitive behavioral standpoint, so the individual has a negative thought, and maybe it's I'm worthless, I'm a piece of crap, I could never do anything right. I ruin everything. When we have those sorts of negative thoughts, they affect our emotions. So they bring our emotions down. So we have more negative emotions. We feel sad, we feel empty, we feel irritable, we feel hopeless. And then those emotions are going to start to affect how we behave. And then that can lead to more negative thoughts, which leads to a more negative or low mood, which leads to behaviors that are negatively impacting our life. Okay, when we talk about treatments for depression, there are things, antidepressants have often been shown to be helpful. And that's because they are affecting typically the serotonin inhibitors reuptake in the brain. Also, dopamine can be another one, but typically we find it's serotonin is the part of the brain, is the chemical in the brain that isn't being produced enough in someone that is suffering from depression. And that is why the antidepressants help with that. Again, cognitive behavioral therapy is a counseling psychology theoretical orientation that is often used to help individuals who are suffering from depression. And so one of the things I want to talk really quickly about before we move on is antidepressants or medication to help with any kind of mental disorder or any kind of depression or anxiety. There will be those that say that no one should take medication, that you should be able to tough it up or only use therapy. That is a personal decision, and if you find that medication works for you, by all means, keep taking your medication. It really is an individual's choice, and no one has the right to tell you, and that includes if you were to ever go and see a counselor or a therapist and you were on medication and you felt that it was working for you, and they told you that they didn't believe in medication, and that they would want you to stop taking that because you should be able to manage your mental health without it. Get up and walk out the door. No one gets to decide but you whether or not medication works for you. And it's the opposite. If you feel that you don't need medication and you are wanting to manage your mental health with therapy only, again, that is perfectly fine, perfectly acceptable. No one has the right to tell you then that you have to go on medication. What we find with depression, oftentimes it can be the combination of antidepressants and therapy that help with ease symptoms of depression. So when we talk about CBT, so I have a few handouts that I'm going to put out for cognitive behavioral therapy. And what they're going to do, the first one is called the cognitive model, and it's just going to kind of walk you through how CBT views any kind of mental health issues. And it really, for CBT, it comes from something happens out in the world and you have a thought about it. And typically if you are having mental health problems, it's a negative thought. And then because of that negative thought, it has negatively affected your mood. And then those two things together are affecting your behavior. And then the next thing that CBT also takes a look at is the core beliefs that we hold about ourselves. And these core beliefs are the most central ideas that we have about ourselves, others, and the world. And these core beliefs are kind of like a lens that we see everything through. Everything that happens, we filter it through our core beliefs. So if we have core beliefs that are I'm weak or I'm unlovable, I'm bad, I'm worthless, the world is a dangerous place, anytime something happens, that's the lens that that experience is going to get filtered through. And so what we do with CBT is we often ask the person to start to track the things that are going on in their life, the situations that are going on in their life, and to particularly pay attention to the ones that they notice that there is an automatic negative thought that follows it. And then what we want to know is when you have that automatic negative thought, what's the emotions that come up? What are the thoughts that come up with it? So one, we're looking to identify triggers. What's triggering these negative thoughts and these negative emotions? But then we also want the client to start tracking how do they behave after they have these negative thoughts and their emotions become more negative. And then we start to look for evidence of whether or not the thoughts that this person is having, are they valid? Or, if, let's say someone gets a D on a test and the person, I'm like, I'm an idiot, I'm stupid, I can't do anything right. So there's the trigger. Getting a bad grade on a test leads to the negative thoughts. Then what are the emotions that come with that? Then what are the behaviors? Because oftentimes for individuals that are suffering with their mental health, it can be that because they feel so bad about themselves, now they don't want to study for the next test because they don't really see the point because they've decided already that they're too stupid to pass the test, so they're not even going to try. Well, then they go and take the next test, they get another failing grade, and it just re-emphasizes that original negative thought. And so what we start to do is we start to go back and look at, okay, yes, you did, get a poor grade on this test. Is that because you're stupid? Or could there be something else going on? Is it because you didn't study? And then we also have them look for, were there times, what other times in your life did you accomplish something? Did you get a good grade on a test? Because what we tend to do is focus in on the negative and we discount anything else anything positive or anything else that tells us that we're not stupid. And so we start to get clients to look for other areas in their life or other experiences where they can see that they are not indeed stupid, that they have passed other tests in their past, and that maybe the reason they didn't pass this test had nothing to do with their intellectual ability, but simply that they didn't spend enough time studying. And so we call these thinking biases. And so CBT will give out a list of different types of thinking bias, kind of this all or none. It's either right or wrong, black and white, one way or the other. Again, it's a disqualifying the positive. It's where we only look at the negative, and anything positive or good that happens, we discount it. Should thinking, I should do this, I should have done that, this should have happened. So those kind of things. And again, I will have this handout out there for you. I'll have a couple of handouts about the different types of thinking patterns that individuals can get caught up in from a CBT kind of point of view. Then I'm also going to throw out, it's the thought, emotion, physiology, and behavior sheet. And again, this is the one where we're asking individuals to become aware of their triggers. So become aware of whatever experience or incident happens that creates a negative thought. And then what are the emotions and what are the behavior that fall from that. Let's see, and I think that's pretty much it there. And so this one is a pretty quick, let me make sure, I think that was, nope, just about it. So there are the handouts. So how do you actually support someone who's suffering from depression? Again, being there to listen is huge. And this is something, some of these you've heard before when we did the suicide lecture. Listening without judgment, listening without criticizing the person, not minimizing what they're going through or their pain that they're feeling, trying to avoid that suck it up, tough love approach. It really doesn't help for two reasons. It comes across as judgmental. It comes across as uncaring. It comes across as you don't really hear what the person is saying, nor do you understand what they're trying to tell you. The thing that you guys are doing, by taking a psychology course is educating yourself, patience, and then know that it isn't your job to fix them. And my job as a counselor is not to fix anyone, but the difference between us is the amount of education that I've had and training that I've had to work with people who are suffering from depression that typically, someone's loved one doesn't have. So while you can be there for them, you can be understanding, you can be patient, you can listen. It isn't your job to become the role of counselor for them. And that's why, it's important for someone who is suffering from any kind of depression to seek help. And I see my battery is running low, and I guess it's a good time. And also just to remember to take care of yourself is important. And that is it for the chapter 16 lecture. And I'll get the handouts out on Canvas, and we'll have the discussion questions loaded up, and those will be due this Friday by 2 o'clock. Have a great week, guys, and I will see you next week.